So, hello everyone from Vienna, Austria. My name is Peter Schellongowski, and I'm welcoming you to a webinar called ECMO on immunosuppressed patients as part of the relatively new EuroELSO webinar series. Some of you may know me from previous webinars because I have been moderating quite a lot of sessions. Today I'm also doing the introduction, but on top of that I will also give the presentation. And I would like to ask Victoria at Interplan to switch the slides so that I can start with my presentation. There you go. And I think you can see my slides now. So when we talk about immunocompromised patients in the ICU, that's one of my topics, being a medical intensivist. I still struggle to understand what immunosuppression really is, and most of all, what immunosuppression not is. And when we talk about the context of immunosuppression and ECMO, everything gets quite blurry, and you will see that we are still lacking quite some data to make some really proficient statements on these patients, on how to take care and what the best management in these patients is. I would like to start off with a case. That's a 21-year-old female with no previous history. She returns from Turkey, which turned out to have nothing to do with her current condition. She's fatigued, she has a fever, and she's yellow. And she presents to a peripheral hospital where in the peripheral blood count, she has a leukocytosis. Her platelets are diminished. She's anemic severely, and we can already see with the peripheral blood count that she's having blasts at 21%. So we already have the suspicion that this is a leukemic disease. And after receiving 2 units of packed blood cells, she goes into acute respiratory failure while still being in the outpatient part of the hospital. Then she undergoes non-invasive ventilation, which she fails, and then she's intubated after only 3 hours. Now, shortly thereafter, we get a call in this situation. She said FiO2 of 1.0, PEEP 14, PPLET 36, saturations at 79. PaO2 51, she's hypercapnic, she's acidotic, and she's having a lactate. She's not prone yet, but to put things together, she's in a very, very bad condition. And this is her chest x-ray after intubation, and we get a request, would you admit this patient for ECMO? And that's a question I would like to discuss with you. You can ask yourself, would you start this patient on VV ECMO? If so, why or why not? And if we take a look into the guidelines, it says that you should consider ECMO if the mortality risk is at least 80%, considering a PF ratio of less than 100 on an FiO2 of more than 0.9 or a Murray score of 3 to 4. And if you do the calculations, this patient will likely fulfill these criteria, but there are also some relative contraindications, as there are no clear contraindications listed here. And that's major pharmacological immunosuppression, and I'm not quite sure what this is actually, or an absolute neutrophil count of less than 400 per cubic millimeter. And having read quite some publications in this field, I'm absolutely unsure where this number comes from. And furthermore, I have to state that I don't think there's a lot of data backing these suggestions up. But let's go on. Furthermore, you would say that terminal malignancy is a contraindication. I think that all of us will agree to that. But this patient is not in a terminal stage of her disease. That's what we can say now. And to take a step back to see what is an immunosuppression eventually, we have some innate or acquired immunodeficiencies, especially the innate ones, are very rare, and most of us will possibly never see such a patient. We have therapeutic immunosuppression in the state of neutropenia, and as I said, additional to congenital diseases, we have the acquired HIV situation. Now, with therapeutic immunosuppression, we're talking about organ transplant patients and also who receive patients who receive immunosuppressives in the course of autoimmune disease. And neutropenia, either drug-induced, which is a rare condition, but most of all, patients after chemotherapy or in the state of bone marrow insufficiency due to different conditions. And if we think about possible indications for ECMO in these patients, we're just going to discuss VV ECMO and acute respiratory failure in this webinar. Empirically, you will have to consider bacterial pneumonia and pneumocystis in the immunodeficiency patients, and infection and also rejection of lung and heart grafts in the organ transplant group, but of course, just as well, infection and in immunodisease, in addition, the underlying disease itself, but also thromboembolic events in bleeding, which is quite often actually an autoimmune disease, and more or less the same mix of conditions applies for the neutropenia patients. So these are the categories of immunosuppression I would like to discuss with you in this webinar. And since we have quite a portion of patients with underlying cancer diseases in my ICU, this will be the main part of the webinar on cancer patients. And while some of us may ask ourselves, do we really need to discuss these very sick patients when it comes down to consider them for ECMO? The reality is that 18% in European ICUs and non-selected ICUs suffer from malignant diseases. That's mainly solid tumors, and of those patients, it's mainly patients who undergo elective cancer surgery, but it's also hematologic malignancy. And if you turn it around and don't look at it from the perspective of the ICU, how many patients of my mix does have a cancer disease, we need to consider that patients with a newly diagnosed cancer disease have quite an elevated risk of going to the ICU in the initial phase of their disease. Some of patients with aggressive hematologic malignancies, in almost up to 20%, will need intensive care unit treatment due to acute organ failure as part of the manifestation of the disease or as a complication due to the initial therapy administered. So it's every sixth ICU cancer patient in the ICU has a cancer disease. So these patients are there, and we really need to consider them and see what the goals of therapy can be for these patients. And does make a difference because cancer patients, once they're admitted for medical reasons, they are different patients. Think of acute hypoxic respiratory failure. We need to consider a lot of specific diagnostic things. We may consider different oxygenation strategies in these patients. Think of infectious complications and emergencies after chemotherapy or adverse reactions to immuno or chemotherapy, thrombolysis syndrome, hyperleukocytosis, which may also manifest in acute respiratory failure, hyperviscosity, some conditions that are not specific but occur more often in cancer patients, such as electrolyte disorders, some coagulation disorders, of course, complications after stem cell and bone marrow transplantation, and a series of issues that will arise only in those patients with a more advanced stage of cancer, probably with a not too well prognosis, such as the typical oncological emergencies like malign airway obstruction, superior vena cava syndrome, malignant spinal compression syndrome, and cerebral metastasis. And you may well argue that those patients most likely are not suitable for ECMO, but sometimes, especially as medical intensivists, we only realize that patients do have one of those conditions, and we need to be fit to diagnose and treat those conditions. Now, talking of prognosis, survival of ICU cancer patients has improved over the last decades, and this reflects, for one, the general advances of intensive care itself, some specific management advances. Think of some, for example, antifungal therapy, empiric or directed antimicrobial therapy, and that we have learned which patient can profit from chemotherapy in the ICU. And then, of course, a major issue is how to select the right patients and which patients aren't likely to do well, so we would not admit them anymore. These are probably the reasons why we have improved outcome. And if you look on the right side at the 1-year survival, in most of the cohorts, it's somewhere between 30, 40, and 50%. And you may argue that's not a whole lot, but if you consider patients who undergo ECPR, patients who go to VA ECMO due to acute heart failure, who may not have the chance to go to LVAD or heart transplant, we talk of 1-year survival rates who are sometimes in some cohorts even markedly lower than that. Now, that's a very important study. I would like to share with you more than 1,000 hematologic ICU patients collected in French and Belgian ICU in a period of only 12 months. The ICU survival is 72 and the 1-year survival is 43, but you can always ask, what kind of survival do these patients have? Are they at the end of their life after 1 year, or do they have a prospect and can go on? So the very important message here is that after 90 days, 80% of those survivors had no alterations of physical or mental health when compared to their state before they had been admitted to the ICU. And after 6 months, 80% of those patients were in remission, and 80% of those patients had overcome their acute organ failures and were in full treatment intensity, so they could carry on with their treatment schedule, having, and this has been shown in several studies, having the same prognosis as a cancer patients who would in between not have been critically ill and who would not have been treated in the ICU. So that's a very promising study, and this has been duplicated by other colleagues as well. I'm not going into detail here, but when you look at the risk factors for mechanically ventilated cancer patients, you will constantly find that mechanical ventilation is really a serious issue, and acute respiratory failure is the main organ failure in these patients. And if we just look at these patients, we see that the prognosis in patients having undergone intubation due to acute respiratory failure, on top of possibly additional organ failures, prognosis has also clearly improved, with an ARDS mortality rate in the year of 2014 of, let's say, only 52%. Of course, that's more than in other cohorts, but it shows that if we treat patients, the proper patient with the proper therapy, in at least specialized patients, for some of those patients or for many of those patients, let's put it like that, this can be a very useful thing. Going into this very study that I just had shown you, we also see again here that hospital mortality has improved. But if we look at the severity of ARDS, we see that we have quite a problem here with patients having or presenting with severe ARDS with 90-day mortality rates somewhere around 80%. Though the question is, would those patients profit from ECMO therapy? Now, in order to set the right treatment goals and to say this is the patients who should undergo full co-treatment without withholding any measures that we can offer in the intensive care unit, I would like to remind you of the factors that are associated with short-term mortality in ICU cancer patients. And if you look at the list, that's factors that apply also for non-cancer patients, but I maybe would like to point out that it has been shown specifically in those cancer patients that late ICU admissions are associated with worse outcomes. So you really want to consider them early once they come down with one or possibly more organ failures, and that only far advanced tumor stages usually associated with cachexia are really associated with short-term mortalities, whereas usually the kind and stage of malignant disease is not associated with mortality. That's a really important message. So you may have an unfavorable 1-year mortality when you look at the prognosis of the cancer, but this does not affect the question, does the patient survive the sepsis? Does the patient survive the ARDS? And this has been shown since 20 years very constantly. So please keep this in mind. Also, neutropenia. There are some recent data that neutropenia may somewhat be associated with prognosis, but in large cohorts with patients with ARDS and hematologic diseases, neutropenia is not an independent risk factor. So please do not turn down a patient when you consider someone for a step up into the ICU just because she or he has neutropenia. Also, recent chemotherapy is not a strong prognostic factor in patients who have undergone autologous stem cell transplant. It's the same thing. And then there may be some factors associated with lower mortality. And I put quite some question marks behind the question of non-invasive versus invasive ventilatory strategies. Some recent big studies have shown that nowadays, most likely there's no benefit from non-invasive ventilation versus O2 insufflation in these patients in order to prevent mortality and in order to prevent intubation. And also high flow nasal oxygen hasn't shown to be effective in one large study by Elia Zolé and his group published in JAMA recently. So there has been a shift of paradigms when it comes down to admitting these patients to the ICU. And if a patient is in remission, if a patient has curative therapeutic options, even if a patient is in palliative first-line treatment but has a life expectancy of more than 1 year, and that is an arbitrary number, and you may or may not agree with that, but that's at least how our community looks at things. If a patient has undergone autologous stem cell transplant, or if it is a patient in whom cure is not likely, but the expected lifespan is substantial, and this group covers a lot of hematologic and oncologic entities and is changing constantly because the therapeutic options are changing constantly. They can be considered for a full co-treatment. Now, if they're bedridden or if they don't have options for lifespan extending treatment, then they should rather not be considered for intensive care either at all or not for a very intensive course. And if you have other situations in between, an ICU trial, a sort of time-limited use of full cold resources may be a good option for the patient, depending on your general management in your ICU. Now, what have we got on ECMO in cancer patients? That's an early report from the EuroELSO registry 2010, and they found 72 patients, most of them with solid tumors, quite a mix between respiratory and cardiac ECMO, also ECPR. And if you not go into the details, but if you look at the survival rates, it's 32%. And the question is, what does it tell you? It's a signal that this may be associated with survival in some patients. It doesn't tell us that there is a cause relationship. And of course, we don't know anything on the details on the cancer status, on the indications, and so on. It's just like a first flag. So the first study or the first case report on 14 patients had been published in 2014 by Philip Wohlfahrt of our Vienna group. These were rather young patients. They all had hematologic malignancies. 80% of those patients were on VV ECMO, and 3 of them on VA ECMO due to mediastinal bulk on top of the ARDS, and 1 with a septic cardiomyopathy after chemotherapy. They had all been on pressors, and a 3rd on renal replacement therapy. And an issue that you will always be worried about is that almost all of those patients were thrombocytopenic, with 1/3 of those patients leukocytopenic. And I want to talk about the complications first because that's a major concern here. 50% bleeding rate, with 6 of those 14 patients having really major events. You see the bleeding sites here, and none of those patients died because of a bleeding, but some of them in the context of multi-organ failure with a bleeding. And unfortunately, one of those patients who eventually survived had to undergo limb he had to be amputated due to limb ischemia after DIC. So that's a tragic part of this patient outcome. Now that's a list of the patients, and I show you the characteristics. They had a PF ratio of 60, high severity of illness score. You will see that all of those patients had a lung injury score that back then would have qualified them for inclusion into the CESAR trial, which is the one that we had back then. Leukocytes around 2 and platelets at start of ECMO at 35. Those are the 3 VA patients. And 4 of those patients had only been diagnosed on ECMO, and 6 of those patients received their first treatment schedule targeted at their hematologic malignancy. And the outcome is a 50% survival rate, not only from ICU and hospital, but also at 36 months of follow-up. All of those 7 survivors were alive, and importantly, 6 were in remission and 1 in relapse. That's just a single center narrative, but it shows that some of those patients who apparently were really sick may make it with ECMO. Contrary, another series, 15 patients here from South Korea. You see that all of them have died. You see the outcome compared to immunocompetent patients here, and also the outcome in immunocompetent patients is quite low. I cannot comment on this any further, but there was just a second larger series of patients that have been published. So when we consider practical aspects such as neutropenia, low platelet count, infection, which kind of diagnostics should we do and which therapy apply, and what considerations do we have to make when we talk about chemotherapy, maybe even on ECMO. The first thing, and I have said that before, just a cohort on neutropenic patients with back then either severe sepsis or septic shock around the first surviving sepsis campaign. This is just to illustrate that just like other patients too, cancer patients with neutropenia have improved outcomes. When we consider severe thrombocytopenia, this is a series that has been published lately from our center. You see the platelet count at the beginning of ECMO, which was at medium 30, so similar to the cohort that I had shown you before. The number of days without heparin treatment was somewhere around 3 weeks, but one of the patients received an ECMO without heparin for almost a year, and you can as well argue if that is a reasonable thing to do. And here's the number of membrane clottings, which was in total 3 in these 6 patients, and major bleedings, which is a concern, occurring in 4 of those 6 patients. And unfortunately, you see in the bottom line that only 1 of those patients survived. So the name of the original publication is that this may be feasible, but maybe futile. So this is also about patient selection. Now, let's get back to our case report. Remember the patient who had undergone intubation now. What are the differentials? I mean, if we put the patient to ECMO, we may achieve some sort of stabilization here, but the thing is we need to make the patient better as well. So the differential cover pneumonia, sepsis, considered Trali only a couple of hours after she received packed red blood cells. This could be bleeding. This could be leukemia, and I'm stressing this since we know that more than 50% of patients with leukemia who present with acute respiratory failure prior to the first course of therapy do have the leukemia causing trouble in the lung, either because there are infiltrates, leukemic infiltrates, or because they may have hyperleukocytosis or some sort of tumoral lysis syndrome that leads to inflammation and worsening oxygenation capacity of the lung. So this is something to worry about, and some of those patients will come down with HLH. So that's quite a large list of differentials that we need to cover, and not applying for this patient because she is just being diagnosed. In other patients, this could be also toxicity after immuno or chemotherapy or cellular therapy, a topic that is arising in our community. You may have heard of CAR T-cell therapy. So it's really important that on top of doing your ECMO management, if you decide to put a patient like that to ECMO, that you really stringently identify and treat the cause of acute respiratory failure. And this is just to illustrate to you how important this is. 1,600 immunosuppressed patients collected within 1 year with acute respiratory failure. And the bottom line in this study was that the failure to identify acute respiratory failure was the only potentially modifiable risk factor for adverse outcome. And this is applying to, depending on the study, 15 to 20% of those patients. So potentially, or most likely, we will help our patients if we identify the cause and then in a second step properly act and treat it. And here again, or here you see also illustrated that undetermined acute respiratory failure was associated with adverse outcome. So what should we do? There's a landmark trial, again by Eliasole in 2010 in the Blue Journal. And what they did is they compared a diagnostic strategy with the fiber optic BAL plus extensive non-invasive diagnostic strategy with a no fiber optic BAL strategy. So that's the non-invasive diagnostic group only. What they found out is that in both groups, the rate of diagnostic findings was about 80%, and that fiber optic BAL only and exclusively led to an earlier diagnosis of pneumocystis. So nowadays it's really tough to say if BAL really has to be performed in those patients. We do in all intubated patients, but in non-intubated patients, this is a procedure which we don't perform routinely anymore. And this would be, this is an adapted list from the previous study, things you certainly should do, and it's quite labor intensive. So of course you will do blood culture on those patients. It's highly recommended to do high resolution CT in those patients, because you may find things that you don't see in a regular chest x-ray, and this is specifically applying to neutropenic patients because they cannot produce that kind of inflammation that shows on a computer on a regular chest x-ray. You want to do an echo. Quite some of those patients do have troubles with their ejection fraction after certain therapies. You want to do a sputum examination for bacteria, fungi, and mycobacteria. You may consider an induced sputum for pneumocystis, nasopharyngeal aspirates for RSV and influenza, and then PCR testing for all herpes viridae, including cytomegalomy, of course, and then circulating biomarkers for fungi. And the list isn't even complete here, so we're talking lactomannan, but nowadays, of course, you would add beta-D-glucan. Then it's some serologic tests for atypical bacteria, urine antigens, and if you do BAL, you may act differently depending if the patient is on a tube or not, and I'm going into detail a little bit later. So what this shows you is that having cancer patients with acute respiratory failure, you really should invest a lot of work and also resources in trying to find the diagnosis, and this is an evidence based or evidence-oriented list here which can help you. Now, kind of helpful in that regard is also the direct approach. What they did here is with the acronym direct, look at the delay of symptom onset, kind of immunosuppression, radiologic pattern, clinical pattern, and high resolution CAT scan findings. And then together with the experience and knowledge of the literature, they tried to match a large cohort of patients with acute respiratory failure according to those categories. And what they found out, that is, if your patient does have neutropenia, if he has a solid tumor, multiple myeloma, if the if the time between symptom onset and acute respiratory failure is less than 3 days, if the patient is in shock, has unilateral rales or unilateral infiltrates, the likelihood for bacterial pneumonia is quite high. Whereas if the patient has been treated with high-dose steroids for a long period of time, or does have a lymphoproliferative disease, or has underwent allo stem cell transplantation, the likelihood for an opportunistic infection speeds up. And if you have a non-treated acute leukemia, it's quite likely that there is a non-infectious cause. Having said that, you would probably empirically start one of those patients of the left column with a broadband antibiotic, which should cover Pseudomonas. You don't want to leave out pneumocystis therapy and aspergillus therapy in those patients with an increased risk for opportunistic infections. And if you have a non-infectious cause, as in potentially leukemia in the lung, which is like an exclusion diagnosis, because we cannot really prove that in those usually very thrombocytopenic patients, sometimes with a bad coagulation, so you cannot really do a biopsy in those patients, then you are into systemic therapy, as in chemotherapy. And if they are an acute respiratory failure, some observational studies suggest that steroids may be efficient in reducing intubation rate and extent of acute respiratory failure. So another very nice review here, and I just want to give you the idea and not go into the details. This is separating patients into the pre-treatment phase, and you see the three most common diagnoses here that you can find in the CAT scan. Patients or conditions that will arise most likely in the pre-treatment induction phase of the disease in the middle column, and conditions that are more likely to occur in the consolidation part of the treatment, which says that you really should be in good standing with your radiologist, because there are a lot of differentials, and proper CAT scan testing can really lead the way here. And last but not least, concerning the very, and I want to stress this, the very important part of diagnosing those patients is a very recent review that I would like to recommend to you, in which it first had been looked at what kind of underlying mechanism causes the immunosuppression, which clinical conditions are associated with those mechanisms, what are the most likely infections, and which kind of diagnostic strategies can then more specifically recommended in these situations. So you may not have to do all of the diagnostics that are available for all patients, but in some patients, some very specific things. And this review is quite helpful and also very, very nicely illustrated. You see here a similar approach to the left graph concerning similar or different CAT scan findings that may lead the way to further specific testing. Talking about empirical antimicrobial therapies, I have only listed some guidelines here. There are numerous guidelines in there, and I would like to commercialize a little bit a consensus statement on the treatment of those patients that we have published only recently. And this is like you can read quite a lot in there and find cross references to other guidelines that may lead the way to you if you are in the situation that you may not ask a colleague who can counsel you in this instance. So how about the concern of nosocomial infection during ECMO? Looking back into the cohort we had published back then on the hematologic patients, that was one of the concerns of the reviewers, and there was an editorial on this. We had performed 110 cultures on those patients, and only 6 were positive. And of these 6 positive cultures, it was 5 catheter-related infections and only 1 urinary tract infection. on top some reactivation of viruses. So may not really be the issue in these patients. Alternatively, it's really difficult to find anything in these patients because they are treated so heavily with antimicrobials. But reports from cancer patients who are not on ECMO tell us that they have quite a marked increased risk for developing sepsis that leads them to the ICU. But there's no really proof that during the ICU, during their stay and during their treatment, they then also have an increased risk of attaining additional infections. So that's a concern which should be mitigated in some way. And I would like to skip this here. Now, how about chemotherapy during ECMO? How about PK/PD issues, toxicity? We don't know much about it, not to say we know nothing about it. So it's a very pragmatic approach. If the patient gets into a condition where life-threatening organ dysfunction is considered to be due to the malignancy itself, and if any therapy, including a systemic therapy, may reverse this organ dysfunction and lead to a survival, then we usually tend in these cases to administer chemotherapy as long as the patient is not in devastating multi-organ failure and bound to adverse outcome anyway. So some reports on allogeneic stem cell transplant patients. If you look at the mortality rates over here, you also see that there are some improvements here. These would be in gray the mortality rates for patients undergoing acute respiratory failure and intubation, and you see that there's also some signals here. In the later years, quite a proportion of patients do survive their ICU stay in specialized centers. And not going into the detail, the combination of intubation and acute graft versus host reaction, at least a non-controlled graft versus host reaction, is associated with the worst outcome, and by most authors and most reviews considered as condition where you should consider limiting ICU treatment at some point, and this is how we deal with the issue. However, a couple of years ago, we collected, or this has been done by the colleagues of the Mayo Clinic. They looked at 2,600 patients after stem cell transplantation and found out that within the first year after the procedure, 15% of patients after allogeneic stem cell transplant came down with an ARDS situation, and that the mortality rate in those patients was high, but also not devastating. And of course, ARDS patients had a worse outcome than non-ICU patients. So what I was going to say before, a couple of years ago, we collected 37 patients within the 9i network, which is directed by Elia Azoulay in Paris, who had undergone ECMO therapy due to ARDS after allogeneic stem cell transplant. Looks in the first instance rather frustrating. We had a 19% survival rate of those patients, and specifically patients early after stem cell transplant. And arbitrarily, we picked 240 days here because that was the best cutoff to divide survivors and non-survivors. Only one of those patients survived. So this would be a condition which we usually would not recommend as an ideal candidate. Whereas I have to tell you, we have just currently treated a patient who came down with influenza and looked just like a typical influenza patient, and we did not really consider that much that the patient had received within the last year allo stem cell transplant, and right now she's becoming off ECMO, so we are still hopeful there. So this should not be a paradigm to not at all consider those patients, but we have to know early after transplant outcome reportedly is really poor, whereas in those very few patients, we have to consider that very few patients who had been placed on ECMO later than those 240 days, or let's say later than 1 year, we had quite a promising survival rate. So obviously these patients are different. Now, if you look at the differences between survivors and non-survivors in the two columns, you see that survivors have been much longer after transplant procedure, that they were on immunosuppressives to a much lower extent. So this is indicating that those patient groups are markedly different patients. So we are talking about different underlying conditions. And the message is that the longer the patient is away from the allotransplant, looking at it as a solitary risk factor, the better the likelihood of overcoming the condition may be. You see in blue here also, none of those patients had been placed on ECMO undergoing NIV, considering that especially in the earlier years, it had been thought that any kind of intubation in allo-SCT patients is devastating prognostically. However, 8 of those patients failed NIV and then had the same unfavorable outcome as in those patients who had undergone intubation in the first place. And importantly, and this is also only regarding the survivors at the bottom, all of those survivors were alive and in remission after 1.5 years after ICU discharge. So also in very selected patients after allo stem cell transplant, ECMO may be an option. How about HIV? This is a basic case series of HIV cases in which they compared the HIV and non-HIV infected patients. And what they saw is that, at least in this rather small study, and there aren't a bunch of big studies out there, statistically there wasn't a difference between HIV and non-HIV patients. And I'm not very much going into detail, but if you care for HIV patients, you will know that nowadays you will have much more patients who come to your ICU due to non-HIV related causes than to HIV related causes, and that HIV nowadays, under proper treatment, probably isn't an independent risk factor for hospital mortality anymore. So why not put them to ECMO? There are some reports, 8 patients with pneumocystis, 5 of them with air leaks, and 50% of those patients surviving. And to my knowledge, the largest case here is from an Arab country here, 22 HIV positive patients with a hospital survival rate of 68%. So given that you have proper help of HIV experts, or given that you are working in an expert center that can deal with such situations, I do not think that HIV should per se be considered as contraindication. How about autoimmune disease? And if you work in an ECMO center, you will very likely see quite some patients that do come down with severe respiratory failure in the course of an acute autoimmune process. So you will have some experience with that, whereas the number of cases with specific entity of autoimmune disease is quite limited. Similarly to cancer patients, also we have a broad range of differential diagnosis. So we are, it's really a demand that we thoroughly check for infectious causes on the one side, but also have a look at if the disease itself couldn't be the cause for the acute respiratory failure. So the differential ranks from infection, disease, and also bleeding, which isn't that uncommon in autoimmune associated ARDS cases. And finding out the truth is really important, because aggressive speeding up the immunosuppression usually is the answer if it's the disease. However, if it's an infection, a different approach may be more appropriate, and of course antimicrobials come in then. So it's really quite a challenge to take the right decisions here. And there's a case series of patients with Goodpasture who have been treated on ECMO here one undergoing lung transplant and the other surviving to recovery. You see the kind of immunosuppressions that the patient received here, and we always will have a reporting bias probably in these things. Consider that, but it shows it can work. It is possible. And talking of alveolar hemorrhage in those autoimmune diseases, this is something I found and I didn't know before. Alveolar hemorrhage is the most common cause leading to severe respiratory failure in patients with Wegener's, in systemic lupus, vasculitis, in polyarteritis nodosa, in other conditions. So it's in a way rare, but it's associated with a high fatality rate. And we have a case here of patients with diffuse alveolar hemorrhage placed on ECMO. They all survived to decannulation, and 3 went into rehab. Those patients, those colleagues here also treated to a specific goal of APTT, so they underwent anticoagulation, and I'm not sure if all of us would do this nowadays with the rather modern hosings that we have and oxygenators, in which sometimes we can afford running them without any heparin. But again, this shows that in some patients this is a feasible approach even in bleeding condition itself. So not to say this is the last study that I'm showing, but that's a study that was published in the Blue Journal on 225 immunocompromised patients on ECMO treated in between 2008 and 2014, and that is, as of today, the largest study on those patients. Most of those patients, again, on VV ECMO, and there was a retrospective analysis, and you see off ECMO in roughly half of the patients, and similarly to many other studies that I had shown you before, 30% 6-month survival. You see that patients with hematologic malignancy had the worst outcome, whereas patients with a solid organ transplant had the best outcome. And what we had looked at in this study was a separation between patients who have had an immunosuppressive state for less or more than 30 days, and there was a difference. And if you take care of our patients, and if you're about to take an individual decision for those particular patients, I'm not quite sure if this is very helpful. And this would be the distribution of underlying conditions. So you see hematologic patients were the largest group, and these are the associated mortality rates. And you see the organ transplant is sticking out in a positive way. And again, this study is giving us a hint, but not so much more, because we don't know so many things about the specific situation of the patient, about the stage of the disease, about the treatment stage, about the cause of acute respiratory failure, and so on. So back to the case report. Please acknowledge that this patient is at the very beginning of a disease, and if this is a leukemic disease, whatever it is, the patient will have a curative therapeutic option. And she's 20 years old, so why not say she's full coat and then, of course, go to ECMO? So this is what we did. She underwent bone marrow aspiration, turned out to be acute lymphoblastic leukemia. She came down with tumor lysis syndrome with acute renal failure. She received a pre-induction chemotherapy on ECMO. Of course, she received antimicrobial prophylaxis or empiric therapy, however you want to call it. No pathogen was identified. She improved rapidly and could be weaned off ECMO on day 3. So this is kind of supporting the theory. This could have been trolley. This could have been, in addition, leukemia in the lung, and then extubated on day 3. She continued with a full schedule of that treatment, and eventually, due to the bad prognostic factors of the malignant clone, She electively underwent allogeneic cord blood transplantation and became a long-term survivor, and she is still in complete remission after so many days. So, concluding, after all, the level of evidence pro or con ECMO in immunocompromised patients is rather poor. There's a series of studies coming up, as in the ECMO case study that's conducted in our German and Austrian network, directed by Matthias Kochanek from Cologne. He did a fantastic job in collecting more than 400 cancer patients who have been treated with ECMO over the last few years, and the manuscript is in preparation right now, so I cannot give you any details, unfortunately. And then we are currently with the 9i network and supported by the ESICM, collecting 600 cancer patients with ARDS prospectively. And we have a specific focus on those with a severe ARDS, and then specifically again on those who would fulfill common ECMO inclusion criteria that most of us within the community would agree with. Try to characterize them, and if feasible, also try to perform a matched cohort of patients who would fulfill those criteria, who would end up on ECMO with those who did not, since this is an observational study. And we are quite hopeful that this is giving us a lot of detailed information on how to treat those, or how to understand those patients better and potentially treat better in the future. Interventional protocols are not in the way as far as I'm informed. So this is what we're looking into in the future. So to summarize, immunosuppression comprises a wide field of diseases. The main problem of those patients is infection as a part of their acute respiratory failure. ECMO may be a bridging tool in carefully selected patients, but in addition to doing ECMO and to doing proper ICU management, it's really key to do a lot about diagnostics and to choose the proper and specific therapy in those patients. As of today, there are not really any fixed standards, and it's a case-by-case individual decision-making. And what we can say, at least, is that probably ECMO can be discouraged in allotransplantation during the transplant period, and probably, and remember this, the patient that I gave you just before, probably within the first year of allotransplant. And with that, I'm at the end of my presentation. I would like Victoria Interplan to switch the slides again. And I am very happy to answer some of your questions if you have some. I did not introduce that in the beginning, but you as participants are very welcome to put in some questions in the webinar tool. And if I get any, I will be very happy to answer them. Alternatively, you may also write me an email. Don't have it online right now. It's peter.schellongowski at meduniwien.ac.at, and you will find that probably on the EuroELSO webpage. Now, if you came in late for this webinar, you will also either tomorrow or the day after find this very webinar for download if you want to look at certain aspects again. And if you have questions that you don't want to raise here in this forum, you can also, as I offered, write me an email. As of now, there are no questions. That's fine. It was quite a long presentation, so we don't need to have a lengthy discussion in the aftermath. What I definitely want to remind you of is come to London in between May 6th and 8th, 2020 to the EuroELSO Annual Congress in London, UK. We have fantastic speakers from all over the world who give you very much up-to-date information on ECMO management and also on associated techniques like pumps and stuff. So this is going to be a very excited, excellent event, and EuroELSO would be very happy to welcome you there. And last but not least, I would like to remind you of the EuroELSO social media channels, as in LinkedIn, Facebook, and Twitter. Stay tuned with EuroELSO to get the latest news and to be part of our community. So finally, I would like to say thank you very much for joining us today. Stay safe, especially in times of Corona, and good luck to you. And remember that you're only safe if your venous line is blueberry and your arterial line is cherryberry. This is Peter Schellongowski from Vienna, Austria, on behalf of EuroELSO. Thank you and goodbye.